My presentation is about Selena Gomez's song My Mind and Me and how it relates to mental health. My Mind and Me is a song about struggling with mental health. Selena Gomez has often opened up in her social networks about her issues, coping with anxiety and depression over the years. In the song's lyrics, the singer explains how she always tries to hide that part of herself, and now she understands that being open about it can help those who feel the same. In My Mind and Me, Selena sings, "Sometimes I feel like an accident. People look when they're passing it, never check on the passenger, they just want the free show. And it's hard to talk and feel heard when you always feel like a burden." Then she opens up further in the chorus, adding, "My mind and me, we don't get along sometimes, and it gets hard to breathe, but I wouldn't change my life." It is estimated that more than 1 in 5 U.S. adults live with a mental illness. Mental illnesses include many different conditions that vary in degree of severity, ranging from mild to moderate to severe. 2 broad categories can be used to describe these conditions: and any mental illness and serious mental illness. Any mental illness recognizes all mental illnesses. Selena had a serious mental illness, commonly referred to a diagnosis of psychotic disorders, bipolar disorder, and either major depression or psychotic symptoms, or treatment-resistant depression. Bipolar disorder, formerly called manic depressive illness or manic depression, is a mental illness that causes unusual shifts in a person's mood, energy, activity levels, and concentration. These shifts can make it difficult to carry out day-to-day tasks. The defining signs of bipolar 1 disorder is a manic episode that lasts at least 1 week, while people with bipolar 2 disorder experience hypomanic episodes. But many people live with bipolar disorder experience both manic and depressive episodes. These changing mood states don't always allow a set pattern, and depression doesn't always follow manic phases. A person may also experience the same mood state several times, with periods in between, before experiencing the opposite mood. Mood changes in bipolar disorder can happen over a period of weeks, months, and sometimes even years. An important aspect of the mood changes is that they are a departure from your regular self, and that the mood change is sustained for a long time. It may be many days or weeks in the case of mania, and many weeks or months in the case of depression. The severity of the depressive and manic phase can differ from person to person and in the same person at different times. Medications. Often people need to start medications to balance their moods right away. You can also have continued treatment, which is why bipolar requires lifelong treatment and medication even during periods when you are feeling better. People who skip maintenance treatments are at high risk of a relapse of symptoms or having minor mood changes turn into full-blown mania or depression. Mood stabilizers also help episodes. Antipsychotics, if symptoms of depression are manic persistent in spite of treatment with other medications, can help. Doctors may prescribe some of these medications alone or along with a mood stabilizer. Your doctor might add antidepressants to help manage depression, because an antidepressant can sometimes trigger a manic episode. It usually is prescribed along with a mood stabilizer. I saw how she related to how teenagers feel most of the time, and because teens don't like to share feelings, and that these statements can lead to mental health issues. Everyone is at some risk of developing a mental health disorder, regardless of age, sex, income, or ethnicity. In the U.S. and much of the developed world, mental disorders are one of the leading causes of disability. Social and financial circumstances, adverse childhood experiences, biological factors, and underlying medical conditions can all shape a person's mental health. Many people with a mental health disorder have more than one condition at a time. Mental illness should not be thought of any different from physical illness. In fact, I believe the two are inseparable, because the whole body is connected and interwoven. The two cannot be separated. The brain is an organ just like everything else in the body and can be hurt like everything else. When the brain is ill, it is not isolated. It is just the brain, but instead affects the whole body and the overall wellness. Substance abuse, self-harm, and suicide are very common and dangerous in those with mental illness. The stigma surrounding mental illness keeps people from getting the help they need to get better and causes them to hide their pain. It is important to note that good mental health depends on a delicate balance of factors and that several elements may contribute to developing these disorders. Types of disorders among youth in juvenile justice settings. Many of the situations can vary. Studies have found that conduct disorder and substance use disorder, alcohol or drugs, to be the most common mental health issues for youth in secure care. Mood disorders, example, depression and bipolar disorder, anxiety disorders, panic disorders, generalized anxiety disorders, obsessive compulsive disorder, disruptive behavioral disorders, emotional behavioral and trauma, post-traumatic stress disorder are also prevalent among youth in juvenile justice setting. Another study indicated that 3% of the juveniles in detention had a psychotic illness, which is 10 times more than the youth in community outreach. Also reveals that youth with mental health disorders in juvenile justice settings are at a greater risk for self-harming behaviors and suicide. The juvenile justice system in the United States is experiencing a social movement aimed at responding to the mental and emotional problems of delinquent youths. Ironically, this movement arose in the wake of a decade of reform in juvenile justice that has set aside the system's 100-year tradition of rehabilitation for delinquents in the interest of their punishment and a primary emphasis on public safety. In only a few years, almost all states adjusted their juvenile laws to fit this image of the new juvenile super predator. The political bumper sticker for the new response to delinquent read very simply, "Adult time for adult crime." These new laws were designed to guarantee that a large number of youths at younger and younger ages are charged with a wider range of minor and major offenses would be tried in criminal courts as adults. Thus, between 1987 and 1994, the number of youths transferred to juvenile courts to criminal court nearly doubled. If youth stayed in juvenile courts, new laws guaranteed that they often would have to face harder sentences than before, emphasizing discipline and deserved punishment. If possible, they would be handed over to adult prisons at the end of their sentence. Mental health disorders are prevalent among youth in the juvenile justice system. At some contact points, as many as 70% of youths have a diagnosable mental illness. This is consistent with other studies that point to the overrepresentation of youths with mental/behavioral health disorders. Youths involved with the juvenile justice system estimates that approximately 15 to 30 have diagnosis of depression or pervasive depressive disorder. 13 to 30 have diagnosis of attention deficit/hyperactivity disorder. 3 to 7% have diagnoses of bipolar disorder, and 11 to 32 have diagnosis of post-traumatic stress disorder. These facts came from West B, Developmental Differences in the Phenomena of Depression. However, prevalence varies depending on the stage in the justice system at which youth are assessed. In a nationwide study, the prevalence of diagnosed disorders increased the further that youths were processed in the juvenile justice system. While it appears to be prevalence in youth with mental issues in the juvenile justice system, the relationship between mental health problems and involvement in the system is complicated, and it can be hard to disentangle correlation from causal relationships between the two. Childhood adversity studies support that adverse childhood experiences such as child abuse, parental loss, parental separation, and parental illness significantly affect a growing child's mental and physical health. There are also associations between childhood abuse and other adverse events with various psychotic disorders. These experiences also make people vulnerable to PTSD. The National Institute of Mental Health suggests that genetic family history can increase the likelihood of a mental health condition, as specifically gene and gene variants put a person at higher risk. However, many other factors contribute to the development of these disorders. Having a gene associated with a mental health disorder does not guarantee that a condition will develop. Likewise, people without related genes or a family history of mental illness can still have mental health issues. chronic stress and mental health conditions such as depression and anxiety may develop due to underlying physical health problems such as cancer, diabetes, and chronic pain. Many youths in the juvenile justice setting have experienced adverse childhood experiences, ACEs, which are stressful or traumatic events that happen to or around a young person. These may include direct emotional and/or physical abuse or neglect or sexual abuse, witnessed domestic abuse, household substance use and disorder, or mental illness, parental separation, or having an incarcerated household member. Research have found that ACEs can have a lasting effect on risky behaviors, chronic illness, and development of mental health and substance use disorders. Research has also shown that youths in the juvenile justice system report higher rates of adversity and trauma when compared to youths in the community and are more likely to have experienced multiple forms of trauma. Center for Disease Control and Prevention. A 2014 study found that 97% of sampled youth in juvenile justice settings reported one or more ACEs. Of these, 90% reported at least 2 ACEs, nearly 75% reported at least 3 ACEs or more. That 50% reported at least 4 ACEs, and nearly 33% reported 5 or more ACEs. Traumatic experiences in childhood disrupts aspects of the brain and personality development in children and adolescents, and compromises their ability to self-regulate. Research has demonstrated that ACEs can affect the self-regulatory areas and the pathways in the brain, especially the prefrontal cortex and the neurological pathways between the prefrontal cortex and the amygdala. Research suggests that youths exposed to trauma are less likely to be able to self-regulate, which increases their likelihood for behavior issues and risk-taking, which can lead to a greater likelihood that they will become delinquent, abuse substance, and/or self-injure. All mental health treatment provided in the justice setting should consider the effects of ACEs and focus on supports and services that build resilience and assist youth with self-regulation skills. Research shows that both juvenile justice staff and mental health staff in juvenile justice settings should receive additional training in working with youths who have experienced trauma. When staff in the justice facilities have a greater understanding of the mechanisms through which trauma leads to delinquent behavior, staff should be prepared to address trauma among youths in their cases. According to the U.S. Department of Health and Human Services, mental health includes a person's psychological, emotional, and social well-being, and affects how a person thinks, feels, and acts. Mental disorders relate to issues or difficulties a person may experience with his or her psychological, emotional, and social well-being. Each of the mental disorders is conceptualized as a clinically significant behavioral or psychological syndrome, or patterns that occur in an individual and that they associate with present distress, a painful symptom, or disability, impairment in one or more important areas of functioning, or with a significantly increased risk of suffering death, pain, disability, and/or importance loss of freedom. The Diagnostic and Statistic Manual of Mental Disorders, 5th edition, is a standard classification tool for mental disorders used by many health professionals in the United States. American Psychotic Association. It includes 20 chapters of mental health disorders, including the following: substance-related and addictive disorders, bipolar and related disorders, depressive disorders, anxiety disorders, obsessive compulsive disorders, trauma and stress-related disorders such as post-traumatic stress disorder and adjustment disorders, disruptive, impulse control, and conduct disorders, neurological development disorders, which include intellectual disabilities, attention deficit hyperactivity disorder, and autism spectrum disorder. A broader categorization divides mental health disorders into 2 categories: internalizing and externalizing. Internalizing disorders, which are negative behaviors focused inward, include depression, anxiety, and dissociative disorders. Externalizing disorders are characterized by behaviors depicted towards a youth's environment and include conduct disorder, operational defiant disorder, and antisocial behaviors. Some tools to identify mental health needs in the justice system. Most tools fall into 2 categories. Screening. The purpose of screening is to identify youths who might require an immediate response to their mental health needs and to identify those with a higher likelihood of requiring special attention. It is similar to a triage process in a hospital emergency room. Although there are numerous screening instruments options, two commonly used are the Massachusetts Youth Screening Instrument version 2 and the Diagnostic Interview Schedule for Children. In addition to tools that screen for multiple mental health related issues, there are also tools that screen for specific problems, such as the Children's Depression Inventory or the Suicidal Ideation Questionnaire, which can help determine if a youth should be monitored for suicide attempts upon entry to detention or resident facilities. The purpose of assessments is to gather a more comprehensive and individualized profile of a youth. Assessment is performed selectively with those youths with higher needs, often identified through screenings. Mental health assessments tend to involve specialized clinical and generally take longer to administer than screening tools. There are numerous mental health assessments. One widely studied assessment which is the Archer-Botch system of empirically based assessment, which includes 3 instruments completed by youth, parents, and or teachers. Some ways to prevent initial justice involvement. Mental health services should be more readily available to youth prior to entering the juvenile justice system. Rather than relying on school resource officers, it is often more effective to have mental health responders within schools, as many behavioral issues presented by youth in the school settings are manifestations of their mental health issues. In some communities, law enforcement agencies are partnering with professionals from community mental health agencies to improve the overall response to crisis involving individuals with mental health needs throughout crisis intervention teams and related training. Providing co-training to police and mental health professionals on how to respond with a person with mental health diagnosis is another effective way to improve the overall outcomes of the contact between police and youth. Finally, communities can provide a center where police can take youth for mental health services and support. These community centers would serve as an alternative to arresting the youth and delivering him or her to detention. Improving mental health screening and assessments in juvenile justice settings. The first step to providing effective mental health services to youth who enter the justice setting is formalized screening and assessment. Although it may not be feasible to complete an in-depth mental health assessment for all youth who enter the system, all youth should be screened into broader categories, such as youth who are likely to have mental health issues and those who are not likely to have these issues. Those youth who are considered to be at higher risk for mental health concerns should receive a more in-depth assessment to identify any existing mental health disorders. It is critical that any assessment tool used should be validated and appropriate for use with children and the youth. Mental health professionals providing mental health screenings and assessments should be giving additional training on the unique needs of youth in juvenile justice settings. Research indicates that among youth in the justice setting, Black youths have the highest rate of mental health illness. However, Black youth, and particularly Black males in juvenile justice settings, are less likely to receive mental health treatment. This disparity in service for Black youths may include bias among the screeners, or it could simply result from the fact that Black youths are less likely to disclose mental health concerns. To improve screening practices for youth, staff should be professionally accredited screeners who use culturally appropriate questionnaires and explanations regarding mental health. Further, screeners should be supervised by other licensed professionals and receive specific training on mental health interviewing and reasons why youths who are delinquent may be reluctant to report mental health concerns. Screening and assessments can provide an opportunity to better inform youths about their symptoms that they are experiencing. Common experiences of people with similar symptoms is an effective method of treatment and their benefits. Studies have shown that the vast majority of the youths in the justice setting with a mental health disorder report experiencing at least one barrier to access mental health services while in care. The most common barrier reported was the youth's beliefs that their problems would go away on their own or that they could solve problems themselves without help from others. Consecutively, effective screening and assessments should include time for staff to explain the results of the screening or assessment, discuss the specific symptoms a youth is experiencing, describe the need for treatment, and answer any questions the youth may have. Providing information about mental health diagnosis and their impact is particularly important for Black youths that combat their disproportionately low likelihood of seeking and/or receiving mental health treatment. Improving mental health for youth in the justice setting is very important. Psychotherapy for youth in juvenile justice setting should aim to help them better understand their specific symptoms, the impact of the exposure to trauma stressors or triggers, social skill development, problem-solving skills, and how to improve family dynamics. When possible, treatment should involve family, friends, and any others responsible and caring adults in the youth's life. Psychotic medication should only be used as a part of a comprehensive treatment plan under the care of a licensed psychiatrist. Additionally, mental health providers are often unaware of the home and community environments from which youths who are delinquent come. Therefore, additional training should increase the provider's understanding of stressors and traumas within the social-cultural context. Further, treatment indicted in the juvenile justice facility should not stop when the youth leaves the facility. Each youth who receives mental health treatment should be supported during re-entry into the community. Facilities should also provide youth with referrals to community-based mental health providers to allow for continuously treatment after leaving placement. Improving education and related services for youth with mental health disorders. Educators in the juvenile justice setting should be aware that mental health disorders could affect students' classroom learning, social interactions. In order for educators in justice settings to be effective, they should receive additional training on recognizing mental health issues, common learning difficulties, and behavioral problems that arise from such conditions, and best practices for curriculum and instruction, as well as managing behaviors without the use of punitive measures. It is important that educators and support staff are equipped with a range of responsibilities and interventions based on the individual needs of each youth affected by mental health disorders, and that they are trained to be flexible in order to provide more or less support as needed. From Children's Mental Health 2017. So that juvenile justice facilities can better understand each student's history and plan for appropriate classroom placement and necessary academic and related support. Facilities should obtain the personal and academic records for each youth entering the facility in a timely manner. To further aid educators in juvenile justice settings, it is effective that formal policies and procedures should be created, also to facilitate the exchange of information between educators and mental health practitioners, to ensure that each are on the same page in terms of the youth's needs and outcomes. Promoting collaboration among mental health and juvenile justice. Although mental health providers and juvenile justice facility staff may have differing philosophies about treatment for youths who were adjudicated, close communication and collaboration between these providers can help establish shared and complementary goals and leveraging available resources to meet the needs of these vulnerable youths. Some of the barriers to collaboration among these partners include a lack of formal service protocols, loose to no working relationships, or collaborative structures among the separate agencies or departments. Large mental health caseloads and high rates of staff turnover, and separate funding streams which make blending and braiding of funds difficult. However, some factors may help promote collaboration, including common clients and goals, formal practices, procedures, and structural mechanisms, and staff personal characteristics. In addition, the following practices promote collaboration among mental health providers and juvenile justice facility staff. Some things that can be issued across practitioners and juvenile justice staff are sponsored joint social events in which staff and their families can get to know each other in a more informal basis, use boundary spanners such as hiring liaisons or coordinators to facilitate agency/department linkages, involve facility education, security, and support staff early in the treatment planning process, Establish formal mechanisms for information sharing while maintaining confidentiality requirements. Co-training and co-locate staff across agencies and departments. Develop shared program manuals. Provide targeted staff training focusing on mental health. Though greater communication and collaboration between mental health and other juvenile justice facility staff as a whole can work towards the shared goal of enduring treatment, education, and the related success for youth with mental health disorders in secure care. The Mental Health Priority Act of 1996 and the Americans with Disabilities Act are two of the most important mental health laws ever developed in the federal law. The Mental Health Parity and Addition Equity Act of 2008 mandates that group health plans and health insurers that provide coverage for mental health and substance use disorders should be treated as the same services they do for medical and surgical care. A civil rights statute known as the American with Disabilities Act of 1990 ADA forbids discrimination based on a person's handicap. Those who have a physical or mental impairment that significantly restricts their capacity to engage in one or more major life activities, are considered to have a disability. Some negative when it comes to treatment is a lack of referrals for treatment. Among youths involved in the juvenile justice system, including those who have been referred to a court or those who have been placed in a resident facility, only a small percentage of these in need of services can access treatment. For example, a 2014 juvenile residence facility census found that 58% reported that they evaluated all youth for mental health needs. 41% evaluated some but not all youths, and 1% did not evaluate any youths. However, it is unknown that many of the evaluated youths received referrals for treatment. In a study from the juvenile courts in Tennessee, Dr. Breda, in 2003, found that fewer than 4% of juveniles who had committed offenses, regardless of diagnosis, were referred to mental health services. A study in Southern California correctional facility also found that 5% of the youths were referred to mental health services. Even among the youths who have been diagnosed, treatment is not guaranteed. The Pathways to Dis-Resistance Project found overall low rates of services provided to youth. However, this depended on both the type of facility in which the youth has been placed, example, state-run juvenile correctional facilities, or contract residential settings, detention centers, and jails and/or prisons. And the diagnosable mental health issues. Similarity, the Northwestern Juvenile Project found that only 15% of youths diagnosed with psychotic disorders and functional impairment received treatment while in detention. A study of mental health delivery patterns in Maryland found that only 23% of the youths diagnosed with a mental health disorder did not receive any treatment. A national study found that even if juvenile justice facilities reported having the capacity to provide services youths in their care, youths with a severe mental health disorder often did not receive any emergency mental health services. Finally, numerous studies have related disparities in regards to which youths are more likely to be referred for treatment. Juvenile detention and correctional facilities may impact youth's mental health issues due to overcrowding, lack of available treatment/services, and separation from support systems such as family members or friends. In addition, for juveniles in the correctional facilities, being placed in solitary confinement or restrictive housing also has the potential to worsen mental health issues from the National Institute of Justice 2016. Greater likelihood of recidivism, given the aforementioned limitations of the justice system. Having a mental health problem while involved in the system can increase youth's likelihood of recidivating or engaging in other behavioral problems. This link has been documented and most frequently for externalizing disorders. For example, in their study of Florida, youths who had completed juvenile justice residential placements, Believable and colleagues, found that current substance use was a predictor of rearrest. In their study of youths who were previously placed in a detention facility, Mallet and colleagues found that having a conduct disorder diagnosis and a self-reported previous suicide attempt predicted subsequent recidivism to detention placement. In their study, almost 100,000 youths whose cases have been processed by the Southern California Department of Juvenile Justice, Barrett and colleagues, also found that an early diagnosis of an aggressive disorder was the strongest predictor of recidivism. Some outcome evidence programs and treatment approaches for justice-involved youths, particularly those involving cognitive behavioral therapy, CBT, has shown positive results. CBT is designed to help youths adjust their thinking and behaviors related to delinquency, crime, and violence. CBT programs have also been shown to be effective in reducing recidivism rates. Research on other program types that specifically target youth with mental health needs, such as mental health diversion initiatives, have also shown positive results. The following are examples of evidence-based programs from the Model Program Guide that have demonstrated positive outcomes for youth with specific mental health needs. The first one is functional family therapy. Is a family-based and intervention program for high-risk youth ages 11 through 18. It concentrates on decreasing risk factors and increasing protective factors that directly affect adolescents who are at a high risk for delinquency, violence, and substance use, and/or behavioral problems such as conduct disorder or oppressive defiant disorder. FFT resulted in a significant reduction in felony crimes and violent crimes and a non-significant decrease in misdemeanor crimes. In addition, a study by Selinska and colleagues found that FFT had a positive effect on youth in the areas of reducing risk behaviors, increasing strengths, and improving functions across key life domains. Multi-systematic therapy is designed to help adolescents ages 12 through 17 who have exhibited serious clinical problems such as drug use, violence, and severe criminal behaviors. Through intense family involvement, MST aims to assess the origins of adolescent behavioral problems and change the youth's mind thinking to increase pro-social behaviors while decreasing problems and delinquent behaviors. MST typically uses a home-based model that serves to delivery to reduce barriers that Office of Justice and Delinquency Prevention's families keep from accessing services. The average treatment approximately occurs over 4 months, although there is no defined length of services. Multiple therapist-family contacts occur during each week. Some benefits of good mental health. Whether young or old, the importance of mental health for total well-being cannot be overstated. When psychological wellness is affected, it can cause negative behaviors that may not only affect a person's health, but can also compromise relationships with others. Some benefits of good mental health is a stronger ability to cope with life stressors. When mental and emotional states are at peak levels, the challenges of life can be easier to overcome. When alcohol/drug, isolation, traumas, or fighting may have been adopted to manage relationship disputes, financial woes, work challenges, and any other life issues. A stable mental state can encourage healthier coping mechanisms. A positive self-image can make a person feel greatly about one's self, which is what Selena Gomez found in herself. Confidence can also be a good indicator of a healthy mental state. A person whose mental health is flourishing is more likely to focus on the good in themselves. They will hone in on these qualities and will generally have ambitions that strive for a happy, healthier life, which is what Selena Gomez did with putting out her documentary, My Mind and Me. Finally, the majority of youths in the juvenile justice suffer from mental health issues. Many have traumatic childhood experiences that may have contributed to the delinquent behavior. Although youth with mental health disorders would benefit most from receiving mental health services in their community, many communities rely on juvenile justice systems to address mental health needs. Research has shown that when youths who are delinquent receive effective mental health treatment, their overall outcomes improve and rates of recidivism decrease. Finally, the best is to adopt common goals for serving youth with mental health needs in juvenile justice settings.